here in discussion. So these are my disclosures. When we talk about this intervention, we have to deal with the task C and D lesions. Probably everybody knows that this is the more complications in these area are aortoiliacal. So the COBUS trial, we all talk about it. Just keep in mind that the covered stents has a more patency rates instead of bare metal stents, and they have a more acceptable patency rates in treatment in test C and D lesions. So this is just a remember. And the other one is the COBA trial from Zaratsis and from Hani Sayed. They showed us also that 225 patients have improved freedom of TLR for covered stents in aortic and iliacs, and comparable midterm performance for aortic covered stents or bare metal stents. This is probably a main interesting part, that covered stents in the aortic or bare metal stents doesn't have comparable midterms results for that one. So kissing stents an alternative. We talk about it, but the most difficult part in that area is the geometry of the covered stents. And this is a high risk factor for restenosis and thrombosis. And this is no optimal reconstruction in the area of the aortic bifurcation. So the first invention was 2030 with Peter Goverde, that they described the CERAB technique. And there is a geometrical consequence of the kissing stents and CERAB technique that we have all see here the radial mismatch. But in these papers also recommended that the part C here in which the iliacs is tapered in the tapered area of the aortic stent. This is the most interesting part here, that the radial mismatch is not that much. And this is the C part here in the CERAB technique. And you see here there's the radial mismatch when the iliac stands in the tapered part placed. This is more 1.5 and 1 centimeter in that area, just in the anatomical part of the infrarenal aortic. That this is the narrowest part. So the mismatch is under 2.3 in the CERAB technique for that one. So this is the first results from the CERAB technique, and we see good results for that one with a good primary patency rate. And I want to show you a record case step by step. It was occluded iliac, both sides, and the infrarenal aortic. And we go to this short video, and then we go into OR with an angioplasty, with an angiography. Doesn't go faster for that one. So here's the aortic bifurcation. You see the occluded on both sides, and it was possible to go through the chronic total occlusion from both sides and replace a stiff wire to that one and make a pre-dilatation with 6 millimeters in both sides. Check the intraluminal area, change in a stiff wire for that one for more stiffness and opportunity to go with the good. After that one, we place the sheets from both sides, and there's a 12 French sheath for the aortic stent, go through the lesions. And this is one of the parts we have to just be carefully. And this is always recommended that the covered stents have to be sheet protected, go through the area of the lesions. And then we withdraw the 12 French sheath in that case and place the aortic stent. And this is 1.5 centimeter above the bifurcation. And we rebuild a new bifurcation with the iliac stents after that. Then we threw back one of the wires There is a post-dilatation in the upper part of the aortic stent. And then is a rechecking is very important, like a normal EVA procedure with a pigtail catheter. And after that, there is the kissing stent 1.5 centimeter in the new aortic stent in the narrow area of the distal part of the aortic. And then there is the placing also with the under protection of the sheets, and withdraw. And after placing in kissing stent technique, we can go further steps, simultaneous dilatation. And after that, we have a good result. So what is the difficulty to that one? We have problems with the re-entry. Mostly have the problems to go from the brachial artery or crossover technique. But I think one of the parts is to use a needle system. And you see here one is in the aortic. There's a through and through wire with the BBAC system and a snare. And it was possible to go through the dissection and snare it. And then we have a through and through wire and can go further in our next steps to build or rebuild a new bifurcation in the AIOD lesions. Another part is using the re-entry needle system in the aortic bifurcation, replace it in the area of the dissection, and then it was possible to go with the needle system through the dissection and place the wire in the aorta. There are other examples for the CERAB technique. I want to show here there was a coral reef dissection and a dissection in the intervention. It was possible to fix it with also a needle system and then go further with the CERAB technique with a good result, and also coral reef and a Lirish system. And it was also possible in small vessels, also in coral reef, and it is possible to kissing stents to reconstruct in the area for CERAB technique. And in conclusion, I have to keep in mind that when you go with the CERAB technique, it's not possible to go up and over with this maneuver for further therapies. It's recommended for covered stents in the aortic and in the iliac for improved TLR. Using re-entry devices for technical success is recommended, and it is a good alternative for open surgery in AIOD lesions, and it's also possible for percutaneous opportunities for that one. Thank you very much.
Thank you, Martin. Have a seat with us, please. I'm glad to call Dr. Prof. Mahmoud Salah.